Welcome to Fetal Board. We're about ready to get started. Today we're going to talk about previable premature rupture of membranes, which is always a very controversial subject about what to do. And Dr. Amrine is here to tell us all what to do, so I'll give him the stage.
All right. I'm assuming everyone can hear me here. Monroe, can you hear us? I thought I saw Dr. Luther in there.
It's all right.
Yeah, okay. All right, so like Dr. Cooper said, I'm Dr. Amrine, one of the third-year residents. We're going to cover previable premature rupture of membranes. Chose this topic mainly because we've had quite a few of these coming into our labor unit or the clinic the last 6 months, and also one case that I think is kind of unique, and you'll see why as I go through some of the literature later on. So what we're going to cover today are just some of the basic numbers. How often does it occur? Some of the anatomy of the membranes in terms of the physiology of rupture, the causes, go over some of the prediction and prevention, defining and diagnosing premature, previable rupture of membranes, some of the management strategies, then the outcomes that you can expect or try to counsel your patients on, with a little bit of review of the literature, and then a case review from this last year. So this doesn't occur often, and it's quoted being 3.7 per 1,000 births, less than 1%. When you look at amniocentesis, which we do a little bit more commonly depending on fetal testing, in the second trimester, it increases to 1%. So that's probably the time you're going to see it most or think of this occurring when a patient comes in after they've had an amniocentesis with complaints. The significance is that neonatal outcomes vary quite a bit based on the gestational age in which the rupture occurs. And as you can see, the neonatal survival has a very wide range, anywhere from 12 to 92%. When looking at some of the basic anatomy, we've got 3 layers of the amnion overall. When you're looking at it, you have 2 fetal layers, which are the most important, the amnion and the chorion. At about 14 weeks, the fusion occurs between these 2 layers, and that's when the unit becomes the strongest. And over time, there's a remodeling that occurs that eventually allows it to become a little bit weaker as we get closer to term. The weakest part of the amnion is actually at the internal os, and the weakening can occur mainly due to what's called the matrix metalloproteinases, or MMPs. There's been some studies on these, which specific ones actually cause the remodeling, and these can be influenced by the environment. And some of the causes of rupture of membranes will increase your MMPs in the area of the cervical opening in the cervical os and weaken the membranes. So this is just a picture reminder. It's a little blurry, but you can see the 2 layers in terms of the fetal layers. Obviously, it is not a very thick structure. They're a single layer of columnar cells, and again, at 14 weeks, they become fused and are much stronger. So the causes, a lot of them are pretty straightforward. Preterm contractions. The mechanism behind that, actually, they believe is what's called the hardening effect. And what happens is contractions occur. There's a cell membrane process in which it becomes brittle as it tries to resist the contraction, and eventually that breaks. Infection, specifically chlamydia, gonorrhea, trichomonas, and even urinary tract infections, causes inflammation, which can upregulate some of those MMPs and cause cell remodeling, which predispose weakening to the amniotic sac. Polyhydramnios, obviously an overdistension. If you have membrane prolapse from preterm cervical dilation, you're prone to have membrane rupture. Maternal smoking is associated with it. Cerclage placement is direct injury to the amniocentesis, as I mentioned. The good thing about amniocentesis in terms of outcome, is up to 94% can reseal spontaneously. Any bleeding in the second and third trimester can also be a cause of rupture of membranes in general, but also previably and preterm. Maternal pulmonary disease is associated or been found to be a cause as well. A history of preterm delivery and or rupture of membranes is another thing to think of why someone may have their membranes rupture pre-viable or preterm. And then an asymptomatic short cervix, less than 25 millimeters prior to 24 weeks, if you're screening someone who has a history of preterm delivery, would also raise your suspicion for membrane rupture when they come in. In terms of predicting and preventing this, it's very difficult, as most of the risk factors that patients have are fixed and we can't remove them. Removing some of the modifiable risk factors such as smoking or optimizing pulmonary disease, increasing or improving their nutrition, treating infections can help, but hasn't been overly successful. There's been looks at progesterone when it comes to preterm labor, thinking that, well, if there's preterm labor process going on, maybe it would help in someone who's had to prevent preterm rupture of membranes. Unfortunately, they found that it had no effect on the rupture of membranes, but because it does help with spontaneous preterm labor, it's recommended for anyone that has that indication. There was some thought that vitamin C supplementation in some early studies would actually help prevent rupture of membranes in the preterm and pre-viable period. But when they did some follow-ups with just doing the vitamin C supplementation only, they found that it actually increased the risk of premature rupture of membranes. The consensus for prediction and preventing this is actually we can't. It's very difficult, and there's no point in trying to prevent preterm rupture of membranes because we can't really do a whole lot about it. We can't predict it, and it's more important to treat and prolong the pregnancy once it does happen. So in terms of defining and diagnosing, the definition you would think would be at 24 weeks or younger or earlier in terms of pre-viable premature rupture of membranes. It's actually defined as less than 23 weeks. And the reason is that when you get 23 weeks, we'll actually treat patients as if they're 24 weeks because of the week of latency that often occurs. So we try to get them to viability. The history and physical, the evaluation should be prompted at any time someone comes in with a suggesting rupture of membranes, or if there's oligohydramnios found on just routine ultrasound. An evaluation should be done to make sure that there isn't pre-viable rupture of membranes. We do a sterile speculum exam. This should include your routine screening for infection, also looking for ferning, nitrazine, pooling, and also looking at the cervix itself to visually inspect what the dilation is and making sure there's no cord prolapse, as that'll change your prognosis and your treatment. We always stress in the labor unit avoiding a digital exam because this can decrease the latency period to delivery. There's a couple studies that were published, one in 2000, one in 1992, that actually looked at patients who were checked digitally as opposed to those that just underwent speculum exam, and they found that the latency period can be decreased by sometimes up to 4 days. And if you think of pre-viable, if someone comes in at 23 weeks, you check them digitally, you may have just decreased their chance of delivering after 24 weeks. It can be complicated to diagnose this at times, especially with patients who have any type of leaking of urine, if they have extensive vaginal discharge, they've had recent intercourse, or do any type of douching, as this can make it difficult to interpret your ferning and nitrazine. In some cases, you can use indigo-carmine injection directly into the amniotic cavity, also known as the Smurf test, to help diagnose difficult cases. Cases that your physical exam is equivocal or you don't see any evidence of rupture, but you have no other cause to why they may be oligohydramnios. And what happens is we put a tampon in the vagina after doing the indigo-carmine and it'll turn blue, and that confirms rupture of membrane. The management in general is can be simple or can be a little more complex. You always want to make sure you redo an ultrasound to confirm gestational age and also estimated fetal weight. You want to look for signs and symptoms of infection, as that's going to change our management, any evidence of abruption, and also advanced labor. The counseling the patient on both her risk and the fetal risk is probably one of the more difficult parts, as there's not a lot of data about it, but you need to try to give them an indication as to what's going to happen and what are the chances of the pregnancy making it to where the baby has a chance to live and have a normal life. You also need to look at what the risks are to prolong the pregnancy to the mom, and make a decision with the patient. Are these risks worth it or not? Previable delivery, it's can get left up to the patient. Oftentimes, it may depend on the institution if they allow a live fetus to be essentially aborted in the previable context, and there's no other reason to. It can also be based on your clinical findings, such as infection, abruption, fetal death, and advanced dilation are usually your indications to go ahead and proceed with delivery. We can do this through a couple different methods. We can do prostaglandin E2 or Cervidil. Cytotec is probably the one we use the most. You can do high doses of oxytocin, or you can do a dilation evacuation, depending on the situation. The actual route of delivery can often be left up to the patient, what their personal preference is, but also the clinical scenario and what resources you have at the hospital. You also need to take into account the patient's previous history, such as C-sections, also whether there's active infection, how far dilated they already are, and also the experience of the physician. Some physicians may not be overly experienced in doing a dilation evacuation of a 22, 23-week pregnancy. Conservative management without any signs that I just talked about in terms of infection, abruption, fetal death, things like that, can be either outpatient or inpatient. If the outpatient setting is chosen, it's recommended to follow the patients every 1 to 2 weeks, reevaluating the amniotic fluid level to see if there's a reaccumulation. There's been studies on actually looking at fetal lung growth to predict hypoplasia, and if there is a slowing of lung growth, it may indicate that the pregnancy has a poor prognosis. However, the ultrasound and the measurements to do this is very difficult and needs a very skilled ultrasound technician. It includes a couple different parameters, such as the actual lung volume and thoracic circumference. Precautions need to be given to the patients. They need to understand that they can become sick very quickly. If they develop any signs of fever, if they have a large amount of continued leaking fluid, severe abdominal pain, a suspicious looking or smelling discharge, or vaginal bleeding are all reasons that they need to get reevaluated, as those are signs that chorioamnionitis may be occurring. They can become septic from this and even have maternal death. Admission at 24 weeks should always be planned, and the patient should understand this so that we can start routine PPROM management since they would be considered viable at 24 weeks. And this is something that the patient should be able to plan for ahead of time because of some of the implications socio and economically. Inpatient setting, it can be a little more aggressive. Usually we do strict or modified bed rest, pelvic rest obviously. Repeated ultrasound evaluation of fluids can be done a little more frequently since they're already in the hospital. The exact intervals is not well described. There is no set interval to recheck the fluid level. Regular assessment for fetal heart tones need to be done. Obviously, if fetal death occurs, then that's your indication to go ahead and proceed with delivery. And there are some studies out there in a couple institutions that are research-based doing interventions for trying to replace or even resealing, so they can try to get the amniotic fluid back up to normal to help prevent lung hypoplasia. There's been some investigation as to, is there a role for aggressive management? We treat PPROM after 24 weeks fairly aggressively in terms of antibiotics, tocolysis, steroids, Well, why not try doing that in the pre-viable setting? It's currently not recommended by ACOG, but some of these may include, or include all of these, starting latency antibiotics, doing amnio infusions, emergency cerclage, starting tocolysis, and trying some of the methods to reseal, which can be done with fibrin, platelets, cryoprecipitate, or there's even a gel foam plugs that have been attempted to do this. The problem with trying to reseal is it's not very effective and it's not very well known the best way to do it. There was a meta-analysis done that looked at all the studies and case reports of attempts of resealing someone who's had PPROM or pre-viable PPROM, and basically the recommendation was it's not indicated and should not be started in routine practice. And as you can see, some of the ones that I highlighted here, I tried to highlight the ones that had more patients because, as you can see, some of these are just case reports. But it doesn't exactly correlate to pre-viable in all cases. Some of these were just PPROM patients. There's very little differentiation between whether these occurred because of amniocentesis or were spontaneous. And the problem with that is amniocentesis, we know where the defect usually occurs. It's where the needle enters. It can be found on fetoscopy, and it can be done a little more easily in terms of trying with the fibrin products and things like that. But the outcome is still not very good. As you can see, there was some that showed a 50% survival. So one of the smaller ones did have 100% survival, but they're, again, that's only 4 cases. And when you look at when they treated and when the rupture occurred, it was after 24 weeks, so it doesn't apply to pre-viable setting. In some that did have pre-viable setting, their survival was only 30%. And then the 3 down here, they did have approximately 50% survivals, but you can see over here there's quite a few complications that occurred. And it takes a pretty skilled, you have to be very skilled in order to do this. There's just not a lot of evidence to do it right now. When we look at our ACOG recommendations, they recommend right now the more conservative management in the outpatient setting or inpatient setting. They recommend the counseling of the patient. You can either do expected or labor if it's indicated. They do not recommend any type of GBS prophylaxis, any tocolysis, any steroids, any neuroprotection, latency antibiotics at all. And there's, in the recommendation, it's not even suggested that this is an option. This is kind of the, if you look at the algorithm when someone comes in with rupture of membranes, I've highlighted the basic pre-viable algorithm. It's pretty straightforward to talk about. If you diagnose it, you evaluate them for infection, and then you can discuss with them whether outpatient setting or delivery is indicated. This is just another algorithm. You can see it's fairly straightforward. And then when you get to 34 weeks, if you can make it that far, we would start induction or deliver by C-section. Now, the maternal complications are kind of wide-ranging. In general, to PPROM, infection, either choreo or endometritis can occur. Abruption, about 4 to 12%. You have to remember that this can either cause the rupture of membranes or may be caused by the rupture of membranes. Maternal sepsis and maternal death are very rare, however they do occur. That's something to think about anytime you're suspicious for infection occurring. In terms of pre-viable PPROM, I kind of mentioned the socioeconomic economic factor. If you put someone on prolonged bed rest, you're increasing their risk for DVT, muscle wasting, bone demineralization, which then can make recovery time longer, and obviously DVT can have dire consequences. But then the financial and social hardships. If someone comes in and we put them in bed rest starting at 14 weeks, there's a potential they could be in the hospital for 14 weeks until they're ready for delivery if they make it that far. That's a lot of time to be out of a job, be at home doing their routine things. Neonatal complications, the frequency, as I mentioned earlier, really varies based on the age at which the rupture of membranes occurs. Neonatal sepsis is always the big worry because of the prolonged rupture of membranes, the chance for ascending infection to occur. Fetal pulmonary hypoplasia is the other big one. As you can imagine, without having a normal amount of amniotic fluid, the lung maturity is going to be behind. Cord prolapse, especially with advanced cervical dilation. Respiratory distress, necrotizing enterocolitis, intraventricular hemorrhage, and death are all kind of the immediate things right after delivery. And then the long-term complications. If these babies do survive and get out of the hospital, what is the outlook for them? Chronic lung disease is probably the most common, but there's also the hearing, visual defects, cerebral palsy is associated with this, and then mental retardation as well. How do we counsel our patients? This is kind of the part that I wanted to focus a little bit more on. And so I did some research in trying to find studies. There's not a lot out there in terms of what are the expected outcomes. What can you tell a patient when they come in with their water broken before 23 weeks as to what's going to happen? So there was one that was just published not too long ago in 2012 looking at neonatal and gestational outcomes. They broke the study, this was a retrospective study, it was done over 12 years, and they were able to identify 36 patients over that time period. So again, it's very hard to even do studies on this because of the incidence. Their incidence in the study was 0.1%. Their mean gestational age at time of rupture is 19 weeks. And the mean latency period was 32 days, but a range of 0 to 137 days. So quite a range. When they looked at the characteristics, they broke it down into two groups. And I'll explain why this is important after I go over one of the others. But they looked at rupture of membranes occurring between 14 and 19 weeks, and then between 20 and 24. And when looking at the perinatal outcomes, in terms of the delivery after 24 weeks, you can see there's quite a difference in terms of the percent. This wasn't necessarily statistically significant when just looking at the delivery after 24 weeks. But it's important, 41% of patients make it to 24 weeks if they rupture 14 to 19 weeks. That's not a lot. 73% if it's between 20 and 24. So there's a little bit better chance we can get these patients to viability if it's after 20 weeks. The actual survival, when looking at just the perinatal survival, when they delivered after 24 weeks is 42% compared to 72% between the two groups. But then if you look at the overall survival rate of people that came in ruptured, it was only 18% for the group overall that ruptured between 14 and 19 weeks. And then 53% for the group that ruptured between 20 and 24 weeks. This was statistically significant, and I think that is something you can try to convey to your patients, that if, depending on when the rupture occurs, it's not a very good outlook overall, but definitely better if it's between 20 and 24 weeks. Still not very good. And again, that's just overall survival rate. This does not, they did not break down the actual long-term consequences and the long-term effects. Another study in 2012 looked at how healthy are these babies? What's the long-term prognosis? This was a retrospective comparative study. This study in particular that makes it kind of hard to generalize is they were looking at the rate of termination, the difference between rates of termination at two different places, two different hospitals, between 2005 and 2009. The reason why they did this is because termination is an option for the patient, so they wanted to see if we are electively delivering patients that are pre-viable PPROM, does that increase the rate of neonatal survival for those that didn't choose it. And what they actually found was that it's unrelated and overall is that it didn't change the difference. And in fact, the more terminations that occur, it decreases the rate of survival in an institution. Now, again, I don't know how clinically significant that is because you're decreasing then the number of potential poor outcomes if you're terminating. The thing I thought was interesting is when you look at survival among live births in the two centers, there was about 95% in one of the centers, about 65% in the other center. If you looked at survival without major morbidity among the live births, there was one of the centers actually had a pretty good outcome, 87%. The other was about 65%. But if you look at the ones, the survival among total PPROM, it's only about 46%, and then 20 in the others. So kind of a range, but still not very good. When you compare it to everyone that came in with pre-viable PPROM, the survival rate's very low, and then it's about the same in terms of without major morbidity among the total group. Again, the literature is not overly good in terms of giving us just straightforward outcomes, but I think this is an opportunity to counsel patients on what the likelihood, what the expectation is, that the pregnancy and the baby in the long term prognosis is not very good, and not giving them false hope that this baby is going to be normal and going to have a normal life. I mentioned aggressive management earlier. It's not routine, it's not recommended, but I thought it was interesting to see, is there a difference? Would this make, could this change our practice and help out these patients that come in before 23 weeks with rupture of membranes? This one, this study was done, I believe, in Japan in 2012. And what they wanted to look at was they were assessing the neonatal and maternal outcomes of pregnancy complicated by pre-viable PPROM. It was a retrospective study. And what they did was they administered aggressive management by doing antibiotics, the typical latency antibiotics that are given in PPROM. Amnio infusion was performed to replace amniotic fluid. Emergency cerclage was placed, and tocolysis was initiated. The problem with this study is, as you can see here, of those that were chosen, it was either aggressive management or termination. There was no control group. There was no, let's see what happens for patients who do not undergo aggressive management and undergo conservative management. So it's hard to take the findings of the study and say this is applicable to practice. However, I think it opens the door for potential further studies. As you can see, their findings suggested that aggressive management can increase the neonatal survival. And you can see from the total number that were started on aggressive management, at time of discharge that were alive were 27, and 9 of those, however, had serious sequelae. When looking at the mean age of delivery, and I mentioned earlier that knowing when the membrane rupture occurs can affect the outcome, this study actually found that 22 weeks is kind of a cutoff period. If it occurs before 22 weeks, there's a much lower chance that delivery can occur after 24 weeks or will make it to 24 weeks. Where rupture at 22 weeks or beyond, there's a better chance that you can get the patient past 24 weeks at time of delivery. And what's shown here that I've highlighted is the mean age at which PPROM occurred in all the infants in the study was 22 weeks. However, when you looked at it, of the babies that were alive at discharge, the mean age at rupture was 22. The mean age of infants that died during hospital stay was 21. If you look at the delivery, it kind of explains this. Overall, the mean delivery was at 25 weeks. When you look at alive babies at discharge, the delivery weeks was 26 weeks compared to 23 weeks when for babies that did not survive. And this was statistically significant in the study. As you can see, the delivery was 23 weeks before viability for ruptured membranes at 21 weeks. This doesn't come without complications. They looked at the percentage of complications that were found in the neonatal period, and they found these are the percentages breakdown. The biggest one was bronchopulmonary dysplasia, as you can imagine, fetal lung immaturity, and the inability to have the lungs mature. This plot over here, I've put in the 22 weeks, this red line here, because that's what they noted was the mean age in terms of survival at discharge, and then also our viability at 24 weeks. The open circles are the babies that were delivered and discharged without any major complications, is noted here. As you can see, a majority of these fell in this kind of right upper quadrant. And you can see the two cutoff lines. That would be your best chance for survival. If your membranes rupture after 22 weeks and you're delivered after 24 weeks. However, there's still quite a few others. The filled-in spaces in the X's are either complications that occurred in the neonatal period or mortality occurred. So with this study and mentioning that 23 weeks is kind of the cutoff for defining pre-viable preterm ruptured membranes, what's the role of steroids if we think of 24 weeks being viability? In a study in 2011 published in JAMA, this was an NIH study that looked at, in general, the association of antenatal corticosteroids with mortality and neurodevelopment outcomes among infants born between 22 and 25 weeks gestation. The purpose was they wanted to determine if giving steroids to mothers between 22 and 25 weeks would have an improvement of outcomes in looking at outcome of the child, primary being death and childhood neurodevelopment. This was a prospective cohort study. They used the National Institute of Child Health and Human Development Neonatal Research Network to compile their data. This occurred between 1993 and 2009. They were looking specifically at births between 22 and 25 weeks and a birth weight between 400 and 1,000 grams. And they were comparing groups of patients who they received steroids or they didn't. They recorded results at birth in terms of complications, discharge, and then an 18 to 22 month follow-up. They had a total of 10,500 infants in this study. In the results that I think is significant is 74% of the infants or the mothers received steroids. The reason why that's significant, when you look at a plot in terms of the throughout their study, the percent that received steroids and broken down into the gestational weeks, 24 and 25 weeks was almost 80% for both received steroids. But when we get 23 and 22 weeks, it greatly decreases. They mentioned that part of this is likely because of the recommendation being the studies done looking at the effects of steroids and lung maturity were done at 24 weeks, and the recommendation was do not give steroids until 24 weeks in the setting of preterm birth or preterm labor. So when you look at the study, specifically the 23 weeks is the part I want to focus on. When you look at the the hospital outcomes for the infants between 22 and 25 weeks, and the complications here on the left, the odds ratio for almost all of these were clinically significant to have improvement at 23 weeks in receiving steroids compared to those who did not receive steroids at 23 weeks. And again, I think this can be taken into consideration when counseling your patients that are at the 23-week time period with pre-viable PPROM, that steroids at 23-week time period may improve their outcome. And it has been shown in general that there is an increased, or there is a better outcome with the steroids compared to not giving the steroids. Another busy slide, this is looking at the outcomes by 18 to 22 months. And you can see, again, I tried to highlight the important parts in the results of the 23-week group, that the odds ratio, again, for some of these outcomes such as death, significant neonatal development impairment, some of the moderate to severe cerebral palsy, blindness, and deafness are all clinically significant for improved outcomes for the group that received steroids versus the group that did not receive steroids starting at 23 weeks. So in conclusion to their study, again, this was done for just normal preterm labor and delivery between 22 and 25 weeks, not necessarily pre-viable PPROM. They concluded that giving steroids to mothers born at 23, 24, and 25 weeks was associated with the lower rates of both mortality and important morbidities, including a lower rate of death, severe neurodevelopment impairment at 18 to 22 months corrected age of follow-up. So this is suggesting, based on their findings, that it would be appropriate to offer patients who are 23 weeks to offer them steroids if there is imminent delivery. And in pre-viable PPROM, that would fall under there's a high chance for imminent delivery. This may improve their outcomes. So a quick review overall of the topic. Pre-viable PPROM is very rare. Again, it's about 3.7 per 1,000 births. There's currently no good way of preventing or predicting when this is going to occur. The outpatient management is acceptable until viability, and this is often what we will do for patients who are not, meet the criteria. There is an indication for delivery when you have things such as infection, abruption, fetal demise. The outcomes vary, and they're very difficult to predict. It does depend on the gestational age of membrane rupture, and that's something to remember when talking to a patient and you get 1,000 questions as to what's going to happen with this baby. There's definitely need for further studies to determine whether more aggressive management is indicated or would improve outcomes in certain cases. I think obviously a randomized controlled trials would be needed. The problem is the fact that this is such a rare occurrence. How feasible is this? I think it's worth considering corticosteroids, or not corticosteroids, but ACS between 23 and 6, and an estimated fetal weight of 400 grams. In patients, I think it's worth talking to them, going over that it may not help, and also looking clinically what's going on. And just remember, this is a difficult thing to counsel the patients on, given the limited data that's out there right now. So I mentioned earlier there was a case recently this year in which we kind of had a unique outcome in a pre-viable PPROM case. So I'd like to go through that just really quick for those that aren't aware of it or were not involved. In terms of our service, I think it'd be very hard that you weren't involved because the patient was here for quite a while. So this was a 42-year-old on initial visit. She's G7 P3123. She presented at 7 weeks to our acute clinic. That was the day we got our dating scan on her. She had previously been seen at an outside hospital for vaginal bleeding and cramping. Her obstetrical history is significant for a couple different things. She had two elective abortions by DNC. She had a history of an IUFD at 7 months. We did not know what the cause was. We could never get the records to find out. She then had 3 successful pregnancies, 2 that were delivered by C-section. She had no significant GYN history, no past medical history. She did have the 2 previous sections, the DNCs. no family history, no allergies. She was on no medication at the time, and she had no social history in terms of smoking as well. Her prenatal labs were pretty routine going through. The one that we still couldn't quite figure out what was going on was her cell-free DNA when she was offered non-invasive testing, given the fact that she was 42 years old, and the findings of PPROM and oligohydramnios was that she had an increased risk on this for trisomy 18. However, anatomy scans did not show any signs of this, and she declined any type of invasive testing like amniocentesis. Her course, she had a total of 18 visits until she was admitted. She was seen fairly routinely. At about 11 weeks, she did arrive to acute clinic with vaginal spotting with brown discharge in the vault. She had heart tones at that time. There was no reported leakage of fluid. At 13 and 6, she had a routine follow-up in which she stated she had had some heavy bleeding at the prior, in which she was treated for a UTI at outside hospital, was told she had a subchorionic hematoma, but there was no further bleeding. After that, an exam continued to just have some scant brown discharge, and there were fetal heart tones present. A week later, she was seen with no complaints. At 15 weeks, she was seen in the ER because she'd had some bloody discharge that was very runny and fluid-like. At the time she had heart tones in the 150s, there was a noted reduced amniotic fluid on the bedside ultrasound, but ferning was negative. She showed up a couple days later. There was no complaints, but on our ultrasound, we got an AFI of 1.3. An exam was, again, without any findings of rupture of membranes. But given the overall picture, it was, we diagnosed her with previable PPROM. We discussed this with Dr. Groom, and given the fact that there were no signs of infection at this time, expected management was an option, and that's what the patient desired. At 17 weeks, she came in again to the labor unit complaining of cramping. She, at that time, even though it's not considered a temperature, she did have a temperature of 100.2. She also had some upper respiratory symptoms at that time. There was no signs of choreo or abruption. She had good heart tones. She was discharged with expected management. She had another routine visit without any findings. She had a level 2 ultrasound and genetic counseling at 18 weeks. The growth at that time was normal. There was a little bit improvement in the amniotic fluid level. At this time, again, the invasive testing was offered. She declined any type of fetal testing, as well as the indigo-carmine test to help confirm PPROM. At 20 weeks, we discussed her results with her of the cell-free DNA. Again, she declined any invasive testing. A repeat growth approximately 4 weeks later was normal. There was a better visualization of the anatomy at that time. It didn't show any evidence of trisomy 18. And then the AFI at this time was actually 10. And so it was discussed that likely what happened is there was either a resealing or there was some other process going on, and that we would plan to admit her at 24 weeks and start with our PPROM management. At 24 weeks, she was admitted to our high-risk OB service. The significant findings at that time was she had had a fetal decel for 2 minutes, so we kept her over there for quite a while. We initiated ACS, but we did not start antibiotics given she was afebrile. There was no signs of infection, and this had been going on already for 8 weeks, so there's probably no indication for the antibiotics at that time. This is kind of the significant things that happened that first week. We finally did get a confirmed positive rupture of membrane exam at 24 weeks and 5 days after she complained of extensive leaking of fluid. We repeated a growth at 24 and 6 that again was appropriate fetal growth. Her AFI during this whole time had fluctuated. It had gotten down, I believe, somewhere between 2 and 3, and then gotten back up to about 13 So it was a wide range of what her fluid level was. 29 and 6, we gave her rescue dose or rescue course of steroids because she'd had about an 8-minute decel on fetal monitoring, and we decided we're maybe close to delivery. Let's go ahead and give her a rescue course, and we kept her over in the labor unit until 34 weeks. When we went ahead with repeat C-section that went without complications, she delivered a 5-pound, 14-ounce male that had APGARs of 8 and 9. She was discharged post-op day 2. The mom didn't have any complications other than a little bit of wound breakdown on her follow-up visits. I could not get a hold of the patient. The best I could find in terms of the baby was that there was some mild respiratory distress requiring CPAP initially in the neonatal time period, and he was discharged at 1 week and 1 day old. And follow-up in the clinic up through September was that there were no major complications. I think there was some worry about weight gain, but it was going to be managed outpatient, and that was the last that I could find the infant had been brought back. So this is kind of is going through everything today. You can see this is not a common course for pre-viable PPROM. However, it did end up with a good outcome from what we can tell so far. So it can happen. And that is all. Questions?
The study that looked at the steroids versus not at 23 weeks, and I don't know if they considered this or how you'd actually measure it. Did they look at the neonatal or NICU resuscitation efforts for the baby that got steroids or didn't get steroids?
They did initially look. They left off any infant that was born prior to 24 weeks that died in the room. Basically, there was no resuscitation available for whatever reason. And then they looked again, adding those in, and it actually showed there was even a more significant outcome or decreased risk of neonatal death when you looked at, including the ones that got none, no resuscitation or anything like that. But that was about as far as they went in terms of looking at resuscitation, was the pre-viable 22 and 23 week births.
Maybe that if any neonatologists are here, if you would comment, I mean, does it make a difference if we've given steroids or not given steroids as far as how hard you push with that baby?
Yeah, I think even if steroids are given, it does make a difference. Even at 23, I don't know what your practice is, but my fellowship is to give steroids at 23 weeks, and the initially impact in sort of aspect of survival was better in babies who got steroids.
And a couple of comments in terms of the Molly Carlin papers again, way down to the left. He looked across all the 14 or 17 neonatal network in ICU. There was no selection. So whatever individual institution practices they do. So they just look at the total outcome. Coming back to our data, unfortunately, our survival and morbidity rate is not very good at 23, 24 weeks. That's the reality that goes. And there are a lot of variations. In terms of hard data, should we all give it? Certainly, the anecdotal data is pretty persuasive, as you pointed out. And I know the maternal fetal network was doing a trial, 2 trials. One is the neonatal corticosteroid, I think between 22 and 24 weeks, and those subjects are very few and far between. And I have not seen any publication, I don't know if you in your literature research, whether you've seen those data, the prospective randomized.
Yeah, I didn't specifically look for that type because it's more generally just preterm labor and delivery without the pre-viable PPROM, so I did not look for that specific.
Sure, I haven't come across it because I presume if it's something dramatic and exciting, you would have done it.
Yeah.
I would have never by now. As one, and two, there's always concern that repeat causes neonatal corticosteroids. And there's also, as I left Detroit, we were part of the network that's looking at repeated doses, how many too many, and this may have 2, but a lot of problem comes at 3, 4, 5.
Yeah, and our general practice is just 2 courses and that's it. And yeah, because of the studies that showed what happens when you have more than that.
But every week you can buy us, and every 100 grand you buy us, it gives the kid a lot better chance.
And
you give the 34 weeks, that's even better.
Yeah, and that's what I think, after looking through the literature, you got to probably select in the Previable PPROM who you give steroids to at that 23-week time period. If you think you're going to get them to the 24 weeks, it may be worth withholding, but if it looks like you're going to deliver sooner, then it may be worth go ahead and initiating the first course at that time. But there's not a lot of evidence to really say either way.
And you mentioned that our data here isn't that great for 23-week survival, but I'm not routinely giving steroids at 23 weeks, and I don't know if that has anything to do with it. I don't know that our practice has been to give it at 23 weeks, at least not routinely. Sometimes Dr. Groom will weigh in and we're giving it, and sometimes it depends on the baby's weight and things like that. But, I kind of held fast to the 24-week, and I don't know if that's affecting our survival rates or not.
I don't think anybody has hard data that say you must give that at 23 weeks.
But 23 weeks is viable, and if you want the survival rates to improve, we can give steroids. If you are going to go and resuscitate the baby, so it will improve our resuscitation outcomes.
So do you think it's the weight would be just as important if it's more than 400 grams, or? I mean, a 20-week baby usually weighs around 500. 22 weeks, they ought to be at least 400.
That's severely growth.
Unless they have growth problems.
But the ones with growth problems, there's no quick answers to that, and they're both important, and I think we have to have a reality check. What the reality check is, they're very premature. We as a group don't do well, but I can also take this point of view, unless you try, you'll never get better. So that's the other thing, and this is the kind of thing we talk about 1,500 gram babies 25 years ago when I first started, and certainly believes that I knew 1,500 gram babies will survive with 98% chance of morbidity free. The only thing about this perinatal, periviable gestation is, and I'm certainly grateful, and I think it's important for neonatology to be involved. I think if the neonatology and the OB have the common agreement before we talk to mom and the family would be far more important rather than some of us say steroids, some of us say no steroids or whatever. So I think if we can talk about it at the front end, have some sort of agreement, at least we can be consistent. The parent won't get a conflicting, even sometimes.